What about in the cases of recurrence of cancer after surgery? And which situations would you then think RFA would be appropriate? Because these types of cancers are probably not going to be the papillaries, are they?
Well, they can be.
Mm-hmm.
We recently did a patient exactly like that. Now, this was off-label. Patient had already had a total thyroidectomy, had already had a neck dissection, and then a couple of years later had a single recurrence in the mid portion of the neck. And we did a radiofrequency ablation on that single solitary spot of cancer. And if you compare it to the risk of going back into an already operated on neck, it really made sense from a risk benefit point of view. So we used it in that situation, and she's done really, really well. It's been about 8 months since we did that case. So far, it's looking really good. But she'd already had sort of maximum therapy. And so she was looking at possible radiation therapy. Well, radiation therapy has a whole lot of side effects that were more than what we were going to encounter with RFA. And doing that didn't burn any bridges. If it grows back from where we treated it, we can still do that external beam radiation therapy. So in that case, it seemed like a very good choice. And when we compared it to the risk and benefits of the alternatives, it seemed very, very reasonable to do that. So again, it will be each case where you do that. Now, is RFA going to work for a neck full of disease? No, not at all. Years ago, people had the idea that maybe you could just pluck out the bad cancer nodes for thyroid cancer. We called it berry picking. And it's been shown that that just flat out doesn't work. If it's spread into the neck, you need to take all the lymphatics, not only the nodes that you can see, but all the little connections between the lymphatics need to go as well. In other words, we want to kind of get beyond the boundaries that we can see and get any microscopic spread out. You can't do that with a targeted therapy like an RFA. So even if you had 4 lymph nodes out here, you might be able to zap the lymph nodes, but you couldn't get all the connections where that cancer came from. Okay, so that's still a surgical case. In the case that I described, all those lymphatics had been removed, but there must have been some microscopic left over because a couple of years later it popped up there. In that case, we did use a targeted therapy. So you have to be very, very selective, and you have to have a long discussion with the patients and review. In this case, this is always scary, by the way. You're talking about cancer and you've already had a treatment and now it's back, or it's somewhere different that you didn't know about before. Those are not quick and easy discussions. You got to talk about a lot of things, the pros and the cons, and what's going to happen with the treatment, what's going to happen without it. You got to consider the morbidity involved there too. So in that particular case that I mentioned, the morbidity of an operation, well, going into an already operating on neck is even more risky than the first operation. So we thought that was a reasonable choice, and so far it's worked out. But again, it still requires careful follow-up and an ongoing relationship with that patient to make sure that we're doing the best we can. And clearly, a little bit more aggressive kind of cancer in this particular case.
I think that's important to make a distinction between, and again, this is for lay people who don't have a background in medicine, but that cancer recurrences are when cancer has already been dealt with and it's coming back. And so when a patient maybe is looking for research that supports RFA for thyroid cancer, if they see, here's an article about thyroid RFA for cancer recurrences, I think that word recurrence might be missed. So it's important, I think, to make sure that patients are aware of the fact that recurrences are not the same thing as primary cancers when they first appear in the thyroid.
Yeah, and let me give you a kind of a little further explanation on that. Okay. So if you think about, let's just say that I have a thyroid nodule here on my right side, okay? So if that was a thyroid cancer and I had that treated, okay, either by surgery or by RFA because it was small, what I don't know at the time is, was there any microscopic spread? Now, I know there's not macroscopic spread because I can do an ultrasound or a CT scan and see that there are no enlarged lymph nodes over here. But what if it was microscopic? And we know that thyroid cancer is slow growing. Well, that microscopic spread might show up 2 years later as a lump over here. It probably came from the cancer originally 2 years ago, but it took 2 years to show up because it's slow growing. When you did the treatment, whether that's RFA or whether that's surgery, you had no way to know that there was a microscopic spread there.
Mm-hmm.
Okay. And you wouldn't do a neck dissection when there's no evidence of disease there. So part of the reason we follow these patients for at least 5 years after their cancer is to pick up those slow growing that might have spread microscopically, weren't visible by any imaging or surgery or anything at the time, but show up later. It's kind of important to think about that cancer, by its very nature, can spread. Thyroid cancer typically spreads not through the bloodstream, but through the lymphatics. And that means it spreads what we call regionally into the region that surrounds the area where it started. Distant mets, like to a liver, to a lung, that goes through the bloodstream.
Mm-hmm.
And thyroid cancer typically doesn't do that, which is another reason we get high cure rates.
Mm-hmm.
Regional spread rather than distant metastatic spread,
Mm-hmm.
right? That's the typical thing for thyroid cancer if it spreads. Typically, it doesn't spread.
Mm-hmm.
But if it does spread, then it's usually a regional spread,
Mm-hmm.
local and regional spread, not a distant spread.
Mm-hmm.
But it can do the distant spread.
And I think that that's important to remember when you're considering, as you said, that this is often a very treatable disease and doesn't have the same weight of severity as a lung cancer or colon cancer. So that's unfortunately why so many people do refer to thyroid cancer as a good cancer. But I tell people, don't ever say that to someone with thyroid cancer, because they will never feel like what they're going through is good.
Yeah,
So.
and you shouldn't say it to a thyroid cancer doctor either.